Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of 10 Clinical Minutes is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represent those of the participants and not of any of our affiliated institutions. Also, a big thanks to Justin Kugel for his editing, support, and creative contributions.
Thank you for joining us on 10 Clinical Minutes. We've been learning so much through this whole process, and we are so glad to have you learning alongside with us. Now, let's get to the episode.
Hey, everybody. So this morning, we're going to be talking about procalcitonin, which feels like the hottest new lab test on the market, which actually been around for a couple decades or so now. So this one, we're talking about the utility of it, and there's a question mark because when I set out to make this presentation, I initially thought procalcitonin is the best test. We should always use it, and we should use it for everything. And as I kind of dug into some of the literature and learned a little bit more about it, I realized, maybe it's not always useful. So we'll talk a little bit about that and talk about what it can be used for, and hopefully get a little bit of clarity and a great case study and why it's important to dig into the literature to find out what it is that we can actually use these tests for. And so just the basics of it, first and foremost, it's called a hormokine because it's a hormone that acts like a cytokine in inflammation and infection. Of note, it's produced by immune cells, so somebody doesn't have an active immune system, they can't produce procalcitonin, or if it's suppressed, they can't produce procalcitonin. And then a normal level is going to be less than 0.1 nanogram per milliliter. If you see a value greater than that, you should think, oh, this might be an elevation. If you see a value less than that, then you have very good confidence that there's not actually a bacterial infection going on. And so on these slides, they're pretty dense. In fact, on the bottom, I have the references here. I just covered up where it is, and then the PubMed ID. I would encourage you kind of to dig into this literature if it's something that interests you by searching for that PubMed ID on PubMed, and then that'll find you. Most of these articles are available full text free. I'm going to focus on the red text and leave the black text for posterity's viewing in our long-term slides. So with infections, it has both a high positive predictor value and negative predictor value for systemic infections. Read sepsis. That was the first thing I was identified for. The strongest clinical indication for it is to rule in, rule out sepsis if you're curious. That's complicated by the fact that procalcitonin often takes a little while to get back to you. There's not a point of care test. Sometimes it takes half a day to a day in a clinical laboratory that's in a hospital. And in a lot of locations, it's actually a send-out test. So it has a high PPV, high MPV, but it is complicated by the fact that you can't just do it and get your answer like you would with a point of care BMP or a point of care troponin or something like that. The course over time matters a lot more. How it is trending is far more relevant to how the infection is being handled by the body than any other factor. But then if it's a local infection, it's poorly sensitive. And that kind of makes sense in terms of if you have a systemic infection, you have immune cell activation all over the body. With a local infection, you don't have the broad immune activation, and thus your levels may not trend as highly, even if you have a raging bacterial infection in one small localized area. So indications. In localized infections, specifically, it's been studied and proven to have some benefit in COPD exacerbations and respiratory tract infections. Part of that is identifying is this a bacterial or a viral cause, and then discontinuing antibiotics, which we'll talk about a little bit later. It's also useful in an ICU where you can individually guide their antibiotic therapy. And this again makes sense if somebody's in an ICU, you're expecting them to be on a long course of antibiotics. How that procalcitonin trends over time can give you a little bit of clue of when you can start to taper back on antibiotics or discontinue them altogether. And then the last indication that really isn't all that helpful at this point is diagnosing or confirming sepsis in an ED. Largely that's limited by the logistics around the test. So then this exclusion criteria, several of them make sense. Immunosuppression, you don't have an immune response. Treatment of local infections, in the case of like if it's on an organ that could be damaged, such as a heart valve, even if there's a low procalcitonin, you're still going to treat it. So don't use it to guide your antibiotic therapy. And then if the organism is really nasty, or if the infection is going to be resistant to treatment, then you're going to treat the infection regardless of what the procalcitonin says. And that's just using clinical judgment to make a decision, not relying only on a lab test. So this is a table, not going to spend time talking through it, that walks through how you would use procalcitonin for initiating antibiotics, and then what you would use for stopping, continuing, or changing based on the level that you get in the lab assay. This is a big long table that I'm definitely not going to read through, that talks about different conditions and then the expected range of modification. And some of these are different reasons why procalcitonin can be elevated without actually representing a bacterial infection. These are here for posterity. These are all available in that first paper that I referenced on the first slide. And so now we're kind of moving into some different literature on how it's been utilized and how it's been studied. All these have been pretty well-controlled studies with good setups, but also importantly, active involvement in the procalcitonin guidance to the folks who are using it. And we'll hit more on why that's important just a little bit. So in outpatients who have been prescribed procalcitonin, they're giving a recommendation based on that level that we saw in that very first chart. If it's less than 0.1 or less than 0.25, don't prescribe antibiotics. The physician was then given a chance to think through his decision or her decision and decide, do I want to continue antibiotics? And relative to the control group, there was a 72% decrease in antibiotic continuation after the physician had seen the guidance on the PCT recommendation. Looks great. You stopped antibiotics, you didn't need to. Perhaps that was for a viral infection, perhaps that was for a small local infection that didn't actually require it. There were a variety of reasons why these were discontinued. In the hospital with COPD exacerbations, this is studied down here on the bottom. Again, the PubMed IDs are listed for you. Exact same guidance recommendations given, and then there's a 32% absolute reduction in antibiotic prescription for COPD exacerbations. There's still confusion in the literature. We're not diving into it today of whether or not you need to do antibiotics for COPD exacerbations. Some would say yes, some would say no. In these cases with the low PCT, there's a high likelihood that it's not actually going to develop into sepsis. And so that's why they're using that as a recommendation. And a 32% absolute reduction means that your NNT would be 3 of physicians who would need recommendations to reduce antibiotic prescriptions. And that's a really good NNT. 2 more of them in the emergency department with respiratory tract infections. Most notably in this study, patients with asthma and bronchitis, which are not indications for antibiotics, did not receive antibiotics. And so they saw a reduction in the antibiotic prescription in those who received the intervention, but most importantly, it really helped emergency department physicians rule out asthma and bronchitis cases as not having a bacterial etiology. Again, you're sparing antibiotics from somebody who would otherwise have gotten them. And then in admissions with community-acquired pneumonia, these are patients who are then hospitalized. The same guidance was given to their inpatient physicians. And you see a 7-day reduction in the average duration of antibiotic therapy with PCT guidance. That was the second part of that first chart that we showed that showed when to discontinue after you initiate. Essentially saying the infection's under control, we can now stop the antibiotics. All these are really great studies. They're showing ways that this can be utilized, but the real question you got to ask is when you get it out of the study and into a more clinical situation, does it work? And so these are 3 different studies, absolutely not diving into all the details here. Pause it, read through them, look up the PubMed IDs, you can see what's there. That put the procalcitonin test into a more real-world scenario where instead of the guidance being presented to the physician directly after receiving the test, the guidance was offered to the physician ahead of time, and there was a form of education prior, and then there was no further education, and they were just tracked to see how they would respond to it. And so in the first one, this meta-analysis, it showed in community-acquired pneumonia a sensitivity of 0.55 and a specificity of 0.76, which isn't very good. And so you can't really use a sensitivity and specificity that low to guide your clinical decision-making independently of other factors. And then in the second study of hospitalized patients who received either a respiratory viral panel or a PCT that was found to be less than 0.25 within 72 hours of admission, you go down here, the PCT group, 32 out of 156, 20.5% discontinued the antibiotics in 48 hours, meaning 80% of those patients who had a PCT less than 0.25, despite the guidance that that would be an indication to discontinue antibiotics, were still on antibiotics after 48 hours of getting the test back. With the respiratory viral panel confirming that it was a respiratory viral infection, only 17.6 of these patients had their antibiotics discontinued 48 hours after receiving the positive RVP. And in this case, they were excluding these criteria here, one of them which is positive bacterial culture. And then this last one where they had both a PCT less than 0.25 and an RVP 2 out of 31, or a positive RVP, only 10% of these patients had their antibiotics discontinued within 48 hours after receiving both of these positive tests. And so there's a couple of reasons that this has been postulated. I think this next study really gave the best recommendation for why that is, and that's that physician clinical decision-making overrules the labs that you get. And so if you have a suspicion that you need the antibiotics, you're going to keep them on because you don't want that individual patient to get sick. But on a population level, this PCT guidance doesn't really seem to be having an effect on reducing total antibiotic exposure for the quote-unquote population that's at hand. And then in the last one, 14 hospitals are giving guidance on utilization in a lower respiratory tract infection, LRTI. There was no significant difference in antibiotic prescriptions, course, or adverse effects within the two groups, the treatment group or the group control group or the group who received the guidance. The ED seemed to adhere to these, 64.8% adherence to guidelines, but oftentimes once they're discharged and have their ED follow-up in the outpatient setting, that initial decision to not prescribe antibiotics was overridden by an outpatient physician who had not received the same PCT guidance. And so that kind of highlights another problem of if you have really good guidance on a test, but the general trend is to prescribe antibiotics, the education that needs to be provided for physicians across the spectrum in order for this to really be effective interventions to reduce antibiotic prescriptions needs to be kind of drilled home. So it might not yet be prime time for this, but it might be coming. So future directions, PCT guided antibiotic duration, PCT guided prescriptions. We've talked about that throughout. There's already some proof that those are helpful in both reducing duration and reducing prescriptions. And then we need some improvement. There are problems in adherence to guidelines. Largely, I think that's due to a lack of education, a lack of understanding of what the test means and when it can be used. And then honestly, to get this to be an effective clinical test, it really needs to be a point of care. If you're deciding whether or not to initiate antibiotics, that's often not a 12-hour decision or 24-hour decision, or in a rural hospital that I was in, a 2 to 3 day decision. You're deciding to initiate antibiotics now, and you're not going to wait on a PCT to come back whenever you're making that decision whether or not to initiate. So currently that's delayed, sent out. It needs to be point of care if it's really going to achieve widespread utilization. So some take-home points. PCT has intriguing clinical utility. Use it for systemic infections. It's limited by provider adherence, the efficacy of the test. And the last one, if a test is completed and it doesn't change anything, it begs the question, should that test have been done? And so for a lot of indications at this point, after doing all of the lit research and digging into this question, I will now be much more hesitant on ordering procalcitonin unless it really fits into one of those specific clinical indications. So thanks for tuning in with us this time. Please go back and read the literature on some of this if this interests you. That is really the way to learn how to answer a clinical question, and you only get better at it by practicing. So thanks for joining, everybody.